After the completion of circulation, with this lecture we begin a new section of physiology, respiration. Respiration is closely associated with circulation, as both cardiovascular and respiratory systems serve their common main function: oxygen and other necessary substances supply to tissues and cells, and carbon dioxide and other metabolic exchange products elimination from the body. Thus, we can give now the following definition to respiration. This is the whole set of processes of oxygen supply and utilization and CO2 formation and elimination from the body. This is a task of respiration. The respiration goes in stages, and this is the first stage of respiration, lung ventilation. Each inspiration and expiration repeatedly, constantly repeated, make the composition of the air inside the alveolar space almost constant. Then, next stage is gaseous diffusion in the lungs. Due to constant regular lung ventilation, the oxygen content inside the alveolar space is high, and so oxygen easily diffuses from the alveolar space into venous blood that is supplied to the pulmonary circulation, while CO2 moves in the opposite direction, from venous blood into alveolar space. This is the process of diffusion, second stage. Then, oxygen that enters the blood should be bound and then transported. And so the next stage is the transportation of gases in blood. Oxygen is transported from pulmonary capillaries back to the heart, to the left side of the heart, and then goes into the systemic circulation and reaches the systemic capillaries. As for CO2, it moves in the opposite direction, from systemic capillaries to the pulmonary capillaries. The fourth stage is diffusion again, but now diffusion in tissues. Oxygen, when it comes to the systemic capillaries, should move into the cells. So first it goes from blood into interstitial space, then into cells. While CO2 makes the opposite way. From cells it moves into interstitial fluid and finally to blood. As a result of loss of oxygen and addition of CO2, arterial blood becomes converted to venous. And this venous blood transports CO2 back to the lungs. And when oxygen reaches the cells, inside the cells, it is used in mitochondria mostly, where cell respiration occurs. This is the last stage of respiration, and you studied this in biochemistry or are going to study as the respiratory chain, where oxygen gradually is used for oxidation of substances, and as a result we get ATP molecules, we get some free energy released, and CO2 is formed as well as water and some other substances. The physiology considers the four first stages of respiration, and this first lecture of all these stages considers the first, lung ventilation. Lung ventilation is the process of simply inspiration and respiration repeated as a cycle into and from the lungs. Let's consider the characteristics of the air, inspired or atmospheric air. Standardly contains about 21% of oxygen and very little negligible percentage of CO2, about 0.03%. During inspiration, portion of this air enters the lungs, replacing the expired air. And as a result, some more oxygen is added to alveolar air and CO2 level decreases. Expired air contains less oxygen, you say 16%, while CO2 level increases about 4%. So basically you may say that about 5% of oxygen is used, taken by the body, and about approximately 4% of CO2 is released. And after each cycle, after inspiration, we have more oxygen and decrease of CO2. But this difference between inspiration and expiration in resting state is not great. because respiration goes regularly, each inspiration, and we replace rather little portion of the total volume in the lungs, which is alveolar space for exchange. And this regular lung ventilation results in almost constant oxygen level as a result. Negligible variability between state after inspiration and composition of air after each expiration is very little difference, less than 1% normally. So this is the base for constant oxygen level in the arterial blood. Regardless of this is a time of inspiration or expiration, arterial blood quality remains unchanged and blood contains enough oxygen to make the arterial blood to bring oxygen to the body. As you may notice from the picture, and generally you know that lungs are not connected to the atmospheric air directly. There is a space between it. This is a buffering and conducting space, which is respiratory airways. Respiratory airways are divided into upper and lower, as you know from anatomy. As for the upper airways, they include nose, nasal cavity, pharynx, and larynx. Here are entry to the nasal cavity, nostrils, then see nasal cavity with its bones concave, and pharynx. And beneath the epiglottis there is a larynx. These are upper airways. Also there are lower airways, which include the all bronchial tree, trachea, large and small bronchi, and the smallest ones, the smallest bronchioli. They are lower airways. Trachea is divided, and then each bronchus is divided into two, and then again into and two, and so there are many subdivisions of bronchi until the last bronchioli. As you remember from histology also, the smaller bronchi contain more smooth muscle cells in their walls. Functions of the respiratory airways. Let's start. There are many functions that are performed by airways. Of course, number one is the simplest function, which is a connection between the alveolar space where gas exchange takes place and atmospheric air. So it is simply function of air conduction. Air passes through these ways for inspiration into lungs and out for expiration. But on its way to lungs, the air undergoes certain changes. Almost regardless of its initial temperature, air becomes warmed. Also, there is a great amount of substance, the smallest particles that can be present, more or less. This amount is removed from the air, and also the air becomes humidified. So in total, this function is called the air conditioning. But this is a complex function that consists of the three parts: the cleaning, humidifying, and warming. Of course, warming is related to the situation when the external air, atmospheric air temperature is less than the body temperature. And in some countries, you may expect that there should be cooling of the air if the air really is hot and its temperature is higher than 37 degrees. But in most cases, and especially here, we have function warming, not cooling. Then, water evaporation. According to previous function, air conditioning, which includes humidifying, you may see that for humidifying of the air, certain amount of water should make water vapor to saturate the air until full humidity, 100% of humidity. And so water is evaporated from the surface of the respiratory airway mucosa. And water evaporation is included into the total amount of water lost from the body. Each day we have certain amount of water coming into the body and certain amount of water lost from the body, and this water evaporation is included, and this is not very little amount. It's about half of a liter daily in normal temperature, not extremely hot days. In hot days this level increases. And water evaporation is not only involved into the general water exchange in the body, but as you know, evaporation, this is a process of conversion of a fluid state of water into gaseous, and this is always the endothermic reaction. It takes energy. So due to this, the airways participate in the thermoregulation because it's a part of our heat loss. If energy is used for the process of evaporation of water, it takes energy, and so it's a part of our heat loss in the body. The next function is the airways are trigger zones for protective reflexes. The receptors are present in the mucosa of the airways, and these receptors may begin the following protective reactions: cough and sneeze. If the upper airways are stimulated by the particles that that are present on the surface of mucosa and stimulate them, and then can initiate the sneezing from upper airways, especially in the nasal cavity. But if there is a stimulation of the pharynx or mucosa or the lower airways, like trachea and lower, they result in cough stimulation. In both cases, the strong airflow should remove the agent, the particle that produces stimulation of mucosa receptors. For removing of particles from the lower airways, cough is enough, and the airflow goes through the mouth. But to remove something that is present in the mucosa of the nasal cavity, if we expire through mouth, even powerfully expire, it will not be helpful. It's necessary to expire exactly through nose. And so sneezing means that most powerful airflow goes on the exit from lungs, goes through nasal mucosa, through nose. This is sneezing. And one more function. This is participation in the sounds formation, in speech formation or phonation. Of course, you know that speech sounds are produced by vocal cords, but vocal cords make their vibration when air passes through them. Therefore, we need to inspire air, and then on the expiration, on the moment of expiration, we can say the phrases word after word, and only when air passes through these vocal cords they can produce sounds. So at least these 6 functions for respiratory airway should be mentioned. But let's consider in more detail the process of the air conditioning in the respiratory airways. Again, it consists of the 3 parts. First, cleaning. They say that about 97 or even 98% of all present dust particles or other particles present in the air become removed while air passes through airways into the alveolar space. So cleaning is a great amount of cleaning, and the remaining 2 to 3% of the particles can be removed inside the lungs in the by alveolar macrophages. Of course, if these particles are of organic origin and can be destroyed by enzymes located in lysosomes of macrophages. If this substance particle is not inorganic, it cannot be destroyed by enzymes, so the macrophages just take it inside, phagocytize, and accumulate these particles. This may happen in case of presence of some particles in the air in the industrial factories also, where, for example, the coal dust or silicate dust or asbestos dust particles are present, and if people even use some protective masks, a certain number of particles can enter, and if they reach the alveolar space, they cannot be destroyed by macrophages. Just macrophages take them inside and accumulate. But generally, our air does not contain much such particles of inorganic origin, and most of dust can be simply cleaved by macrophages. Or actually, you can see from these values, most of dust simply does not reach the alveolar space, and it's caught by the mucosa of the airways. Then humidifying. Humidifying goes until the air reaches exactly 100% of humidity. You studied in physics that humidity can be different, and if maximal humidity for this temperature can be taken as 100%, real humidity is expressed in this percentage. For example, the external atmospheric air in Minsk mostly has high level of humidity. Of course, it depends on day, but level of humidity is high, sometimes 70, 80, or 90. But regardless of initial humidity of the air inspired, while the air goes through airways, humidifying occurs, and this air that reaches the alveolar space is already 100% saturated with water vapor, so it's maximally humid. And inside the alveolar space, humidity is maintained at this high 100% level. And last, warming occurs also up to normal body temperature inside in the core of the body, which is about 37 degrees. Of course, if you inspire extremely cold air and with extremely high rate of ventilation of lungs, the temperature will decrease eventually. But under normal circumstances, we don't have this decrease, and on the cold weather, we have little decrease of opening of airways, and the amount of air passing becomes less, but still it can be warmed up to or almost up to normal temperature, even in cold weather. So all this makes totally the conditioning. Let's again consider how the cleaning is achieved. First simplest cleaning occurs due to presence of the little nose hair bundles. These nasal hair located in the entry, in the nostrils, and they help to catch the largest particles present in air, suspended in the air. Then, most important perhaps, is the mucus sticking properties. Mucus covers the mucosa. Why mucosa is called this way? Because it's covered by mucus produced by goblet cells, and this mucus is sticky. So, if suspended in the air particle comes in contact with the mucus on the walls of the bronchi, these particles become simply glued, something like glued to the mucus. And let's observe how it goes. First, these are nasal hair bundles, nasal concha, pharynx, and these triangles show example of the dust particles. The first one is largest, the biggest one. Such a big particle will be simply caught by nasal hair bundles. As for the smaller particles that pass by these bundles of hair, when it enters the nasal cavity, these particles become involved into turbulence. While turbulence occurs inside the nasal cavity. In this picture you see, and from your anatomy study you may remember, that there are 3 conchae in the nasal cavity. They are very thin bones, like crumpled paper, and it has very complex three-dimensional shape. And air does not go simply like through tube. It goes between these pieces of the conchae, and inevitably turbulence appears here. And due to this turbulence, the probability of contact of particles with mucosa greatly increases. And it goes like this. And particles become simply stuck. And mucus of the nasal cavity actually is removed out of nasal cavity simply into the nostrils. Of course, normally the amount of mucus is not great, and we even don't notice. When it comes closer to nostrils, it becomes dry, and simply like a little dust is removed. And of course, when you have running nose, it's easily noticed. But in both cases, it's a protective function. Then, it's not all for air cleaning. Then, the most important is next, and one of the most important factor is regular ciliary movements of mucosal cell, and these movements direct mucus drift to the upper airways. So not all the particles become simply stuck to the mucus in the upper nasal cavity or upper airways. Some particles can move downward to trachea and bronchi, but here cilia are present on the surface of cells. And this cleaning by cilia movements is called mucociliary clearance. Look at this picture. These are cilia of bronchial epithelial cells. And actually they look like seeds underwater. And these easily moving cilia. Cilia are involved into regular waves of movement. And this movement starts from the lower airways, and as a wave goes up and up and up. And so gradually all cilia produce strong movement upward. And this wave starts beneath and goes up and up. And so it creates the constant little flow of mucus upward against the gravity. So, due to this drift to upward direction, mucociliary clearance sometimes also is called mucociliary escalator. And really it escalates, takes upward the particles that are present on the mucous surface. So mucus gradually is removed. And look at this green arrow. When it reaches the epiglottis and reaches the area where swallowing is possible, this excessive mucus is simply swallowed. And in case it has particles that can be digested, they are simply digested in the stomach. If it contains bacteria, most of them can be killed by stomach acid. So mucus moves upward, and finally is swallowed. All this taken together provides great level of cleaning, as you can see, 97-98%. And as for humidifying and warming, they are achieved due to vascular plexuses of nose and bronchial mucosa. So, not deeply close to surface, we have in the mucosa layers, we have vascular plexuses, and these large vessels produce evaporation of water and give additional heat to the air that passes through bronchi. And so as a result, the air becomes humid and warm. Water vapor and heat is both taken from vascular plexuses. So let's consider the laws of the airflow through respiratory airways. And here we have similar laws for the hemodynamics. The same characteristics. So why the air flows into or out of the lungs? Because of the pressure difference between atmospheric air and the alveoli. For the inspiration, we should create pressure in the lungs lower than atmospheric. As you can understand, atmospheric air pressure does not depend on us, and so we should modify pressure in the lungs in order to create difference directed into the lungs or out of the lungs. So when we need to have inspiration, the pressure in the lungs should become less than atmospheric, which is created by dilation of the chest cavity. And pressure decreases and air enters the lungs, while during expiration the chest cavity size decreases, so it creates the pressure higher than atmospheric, and air goes out, part of air goes out into atmospheric, until the balancing of pressure again. And airflow is subjected to the same laws as fluid flow in hydrodynamics, as I already said. This is the same equation that is taken from the fluid from hydrodynamics and we used in hemodynamics. And perhaps you remember that originally this equation comes from the electric physics, that it's analogous to Ohm's law, that fluid but not current, electrical current flow intensity is proportional to the moving force. Here it's moving force difference of pressure, and it's inversely proportional to the resistance of the airways. So, as for airway resistance, again, it's similar to the resistance that we considered in the circulation in hemodynamics. It's also inversely proportional to radius. The length of the airways is important, the characteristics of the air are important, but number one factor, as usual, is radius, because it's always in the force power, and resistance is inversely proportional to the radius in force power. So when we need to increase resistance, radius should be decreased. And for decrease of resistance, radius should become higher. And little changes of radius are enough to create serious changes of the resistance. And radius depends on the bronchial smooth muscles. If these smooth muscles are relaxed, the bronchi become dilated. When the bronchial smooth muscles become contracted stronger than normally, there is a constriction of bronchi. But normally smooth muscles of bronchi are constantly contracted to a certain degree. This is normal situation for the resting state. Because at rest we don't need great amount of air enter the lungs. If you look again at the equation Q equals to ratio of delta P and resistance, look, when we are at rest, we don't need to have great amount of air supplied to lungs. It's enough to have not much. But when the oxygen requirement increases according to increased activity level, so we need to increase amount of air that is supplied to the lungs to have more oxygen finally. In order to do it, we need to have greater difference of pressures. And it can be achieved by deeper inspiration and correspondingly stronger expiration. But also we can decrease resistance. And resistance decrease occurs when there is a dilation of bronchi. So radius increase produces decrease in resistance. So, and we have both changes that occur in case of physical activity. And both changes are achieved through sympathetic stimulation, because sympathetic system makes respiration stronger and deeper, and it dilates bronchi by relaxation of smooth muscles of bronchial wall. I hope you remember that bronchial smooth muscles have double innervation from both sympathetic and parasympathetic system, in contrast to vessels which are innervated almost by only sympathetic nerves. So bronchial constriction is caused by parasympathetic stimulation. And these are vagus fibers that release acetylcholine, which binds to muscarinic cholinergic receptors. So the vagus influence is normal, resting, constant influence. Similarly to the heart influence, the vagus constantly sends impulses down to the heart and produces its inhibitory effects. And here also vagus constantly keeps bronchi more or less decreased in their size, because for resting state we don't need maximal or high level of opening of bronchi. And so smooth muscles are more or less contracted. And mechanism of influence of acetylcholine to muscarinic cholinergic receptors can be predictable if you know that it results in contraction of smooth muscles. It's easy to predict that it goes through phospholipase C pathway. Transmitter binds to muscarinic cholinergic receptors, most widespread M3 type, which operates through GQ protein. GQ protein is not shown here, but I believe you remember that first, of course, activation occurs for the GQ protein, which in turn activates phospholipase C. Phospholipase C produces two second messengers at once, inositol triphosphate and diacylglycerol. And inositol triphosphate opens channels for calcium in the endoplasmic reticulum in smooth muscles of bronchial wall. Higher calcium, higher contraction degree. So there is a constriction. And contraction for smooth muscles, constriction for bronchi. So it's usual way of keeping bronchi more or less constricted at rest. When vagus influence increases, there is really constriction, because normal tone we don't name constriction, but constriction is something more than usual. So, also in pathological cases, constriction of bronchi may occur under action of histamine. We studied already the blood and tissue mast cells. Their granules contain histamine, and this histamine normally is released in minute amounts, but in case of pathology such as asthma attack and generally allergy, But exactly for the bronchi, it's the asthma attack. Histamine can be released in large amount, and so the histamine produces great the constriction of bronchi, and it acts not only on smooth muscle cells, but also it produces edema of the mucosa. And you understand that if there is edema of mucosa, the bronchi don't have bronchial mucosa cannot be dilated because the cartilages prevent their edema going outside, and only inside the lumen becomes decreased. So not only due to contraction of the smooth muscles, but also due to edema of mucosa, and also even hypersecretion of the mucus, and this mucus becomes too viscous, hardly moving, and it blocks the remaining little lumen. So it may produce serious suffocation attack in case of severe asthma attack. So, and some irritant substances in the ears also may produce contraction of smooth muscle cells in walls of bronchi and constriction. Then bronchial dilation. It's necessary when we need to get more oxygen, and it means generally that it occurs due to sympathetic stimulation. And sympathetic stimulation occurs through the same receptors that dilate vessels. And sympathetic transmitter, norepinephrine, and sympathetic agonists, which are hormones, epinephrine and norepinephrine, they all bind to adrenergic receptors of this type, and this is beta-2 adrenergic receptors. Norepinephrine released from sympathetic bronchial fibers binds to these receptors, and also adrenaline as a hormone, or epinephrine, binds to these receptors, and adrenaline acts on all beta receptors stronger than norepinephrine. But resultant mechanism is the same. Beta-2 receptors, as you remember, here produce similar changes, like we have changes in coronary vessels or vessels of the skeletal muscles. Beta-2 receptors, after binding to noradrenaline, norepinephrine, activates GS protein, then adenylate cyclase is activated. It produces a lot of molecules of cyclic AMP, then cyclic AMP molecules activate numerous protein kinases A, and protein kinases A phosphorylate certain proteins which finally decrease calcium. Don't mix with beta-1 receptors in the heart muscle, where protein kinase A activation results in higher calcium level because of opening of additional calcium channels. Here calcium is decreased, and smooth muscles are relaxed, and bronchi become dilated. So here the mechanism goes exactly the same way as we have in vessels such as coronary vessels and skeletal muscle vessels that contain beta-2 adrenergic receptors. So it results in relaxation of smooth muscles. So when we have physical activity, it's clear we not only breathe deeper and stronger, but also our bronchi become dilated so that more air can pass through these bronchi into the lungs. Mechanics of breathing. Of course, something you know from anatomy, but let's go deeper into these mechanics. First, inspiratory muscles. All muscles that are able to make larger size of the chest are inspiratory, but number one, it's clearly this one, diaphragm. And also additional muscles, they are not called additional, they also are included into main, because additional we list separately. But additional to diaphragm, there are external intercostal muscles. Look at this picture. Diaphragm contraction produces elongation of lungs in a vertical size. This size will become larger. Know that diaphragm during contraction goes downward. Its center, tendinous center, becomes lowered, while the peripheral muscle portions make the diaphragm not so extending upward. So it goes downward during contraction and pulls the lungs together, and lungs become longer in vertical direction. External intercostal muscles contract and produce increase of the anterior-posterior axis of the chest. And also slightly it becomes wider. But most change of size occurs in the anterior-posterior diameter. In case of normal quiet expiration, actually we may say that just to relax inspiratory muscles is enough to produce expiration. So we say that normal quiet expiration is usually passive, but not necessarily. In many people we use unconsciously use additional muscles for expiration. But let's come back to accessory additional muscles for forced inspiration. When we perform physical activity, normal classical inspiration is not enough. It's necessary to make it faster and stronger, and additional muscles are involved in this process. And these additional muscles are sternocleidomastoid muscle, anterior serrative, and scalene muscles. All these muscles help to enlarge the chest cavity. And accessory muscles for forced expiration are abdominal muscles. And also internal intercostal muscles take part in this process. So intercostal muscles are of the two types, external and internal. While external are necessary for inspiration and they participate always, internal intercostal muscles more or less participate in their expiration. Abdominal muscles perform their function in helping to expire by creation of higher pressure in the abdominal cavity. So it pushes diaphragm upward, thus contributing to the expiration. Let's consider the difference in external and internal intercostal muscles. It's necessary to understand why muscles located between ribs, intercostal muscles, may produce exactly opposite functions. External contribute to inspiration, while internal for expiration. This is the vertebral column and ribs. And muscles are shown of two types. The upper shown are external. Of course, in reality, they are present in each intercostal space, both of types of muscles, but for schematic purpose, we separate about only external. And let's consider, when these muscles contract, they move the ribs, and the ribs can move only in these shown now pivot points. Here, the change of angle can occur when ribs move. And points of the force application are located at a different distance from pivot points, so that while the same force acts, it makes difference due to different distance until the force points of force application. When muscle contracts, the force of contraction is equal. When muscle contract, they try to pull both ribs together, and so force is equal, but nevertheless the movement of ribs, upper and lower, are different movements. Distance is different because of difference of these arms of force. Here arm of force is shorter and for lower rib is longer. With longer arm of force, the same force acts stronger as a result. This is so-called moment of force, becomes higher. Moment of force is a multiplication of force itself by the arm of force distance. So as distance 1 is shorter, the total moment of force is less. And for red D2 distance, we have longer moment of force, and so lower rib moves more upward than the upper ribs goes downward. So mostly all ribs goes upward. And as a result, it increases the chest volume and contributes to inspiration. Now let's observe the internal intercostal muscles, which are shown lower. Now we compare these two distances. And now short distance is for the lower rib, shorter distance, and correspondingly longer distance for upper rib. And again, you see, all the variable things in the equation remain the same, just we move shorter arm lower, and everything remains the same. D1 still is shorter, and D in red is longer. So here the upper rib have greater movement downward than lower upward. So upper rib downward shift is higher. So predominant movement, and not only this rib but all the ribs that contain these muscles, and they all contain. So as a result, the total chest volume decreases and it contributes to the expiration. So, but it's just for understanding. It's not something that requires deep study, but I hope it's clear just why one type of muscle produces movement of ribs upward and the other type of muscles produces movement of ribs downward. Now, lung volume increase at inspiration. Look, now we can compare. Of course, we consider maximal changes, and under normal resting state, we don't breathe so deeply. You see, this is lung size before inspiration, or you can say after expiration. And then during inspiration, let's take maximal and observe. Diaphragm goes downward. In case of deep inspiration, it goes downward strongly. Then, due to contraction of intercostal external muscles, rib cage becomes increased in size in anterior, posterior, and also in lateral sides. And as a result, you see how bigger lungs can become when, at least when diaphragm goes downward. Already it makes great increase of the volume of lungs. Also, we can observe it on X-ray. Here you see a state of full expiration, and lungs outline is shown. And this outline is preserved, and you can see now lungs at full inspiration. And you can compare how big is the difference between lung size after full inspiration and after full expiration. Of course, in case of resting respiration, we don't need such a great degree of fresh air addition, and we need just a little, the increase of the volume inside the lungs. And you should remember, and you can see from pictures easily, that maximal contribution to the lung volume increase during inspiration, of course, it's due to diaphragm contraction. You see how much lower it can go, so that lungs are stretched strongly, and volume of lungs increases dramatically. Now, it's this important question: why do the lungs follow the chest expansion? You remember from anatomy perhaps that lungs are not fixed in the chest cavity except for the roots in the middle, in the mediastinum, where the bronchus enters the lung, and also we have artery and vein. Artery that goes, branch of pulmonary artery goes into the pulmonary circulation, and then coming back to pulmonary veins. All this area where lungs are fixed, it's the only one point. All the rest, surface of lungs, is not connected, not glued to the chest cavity from inside. Oppositely, it's covered by pleura, and this pleura forms intrapleural space, because one pleural part is the visceral. It covers exactly the lungs, fully covers the lungs. It's a visceral pleura. But then there is a parietal pleura part that covers from inside the chest cavity. And between these two pleura, this closed space entirely, because it comes from the surface of the chest cavity and then goes to cover the lungs, so that it's one and the same closed bag, but this bag or space is very little. Actually, it's a fissure, it's not a space. It's much, much less than this picture shows. Look, this is parietal pleura that covers the superficial, that covers from inside the chest cavity. And this is the visceral pleura part that covers the lung tissue itself. And all this composes the fully closed space. And space, it can be seen only on this schematic picture. In reality, this is very, very narrow fissure between two spaces. But this space is filled with fluid. Fluid, as you know, cannot change its volume in the closed spaces. If, for example, air we can compress, or we can stretch, rarefy to a certain degree. It resists, but it can be stretched and rarefied. and can be compressed, but the fluid simply cannot be compressed. It's too tightly packed with molecules, and compression as well as stretching is not possible. So this is fixed volume, and any attempt to change this fixed volume immediately changes the pressure. And this pressure inside in intrapleural space is negative. Negative, less than atmospheric. What means negative? It's less than pressure in atmosphere. And during normal quiet breathing, this pressure is about -3 to -6 millimeters mercury at expiration, 3 to 6 with minus, and from 6 to 9 millimeter at normal quiet inspiration. With deep inspiration can become even more negative, but note that pressure after inspiration becomes less. And why it becomes less? Because lung stretching degree increases. Lung tissue is elastic, and as like a spring stretched produces stronger force directed back, opposing stretching, the lung tissue also produces opposition to stretching, and this force is called elastic recoil. Elastic recoil. So this elastic recoil is directly proportional to the degree of stretching. With inspiration, we have greater degree of stretching, and this stretching attempts to increase volume of the intrapleural space. So attempt to increase volume in a non-stretchable area produces decrease in pressure. We observe on the next slide again. So at deep inspiration we can reach even more negative values. Let's observe the reason of negative intrapleural pressure. And this reason is the elastic recoil of the lungs. Elastic recoil of the lungs, it's always, this is force that is always present, force that is opposite to stretching. Lungs are stretched constantly. Just degree of stretching changes, but they never collapse fully, and so elastic recoil is always present. Like if you have a spring and you don't stretch it, it doesn't have elastic force directed oppositely. But if we try to stretch the spring, it immediately shows the opposition, resistance. And the highest degree of stretching, the higher becomes this elastic force. And lungs are never collapsed, so they always are stretched, just to less or more degree. These elastic forces that oppose stretching, directed oppositely to the direction of stretching itself. Lungs are fixed, as you remember, in the roots area. So lung stretching goes from the roots in all the directions. Actually, lung tissue, if not opposed by closed space, intrapleural space, may become become simply collapsing to the roots of the lungs, and it makes a piece of tissue, soft piece of tissue. But let's observe again. Stretching is directed from the roots to all the directions to the surface. Corresponding elastic forces, elastic recoil of the lung is directed from surface to the roots. So lungs constantly tend to try to become collapsed. And this elastic recoil also is supported by the chest elastic forces. Of course, chest elastic forces are smaller than lungs, but it's also present. And chest cavity tends to become larger. Mostly we have the cross-section of the chest cavity in horizontal plane, we have the oval. And in reality, rib cage tends to become more rounded. And you see, we have forces that are opposite. And all these forces tend to try to enlarge the intrapleural space. Lungs attempt to collapse, and they pull the visceral pleura from parietal. And also the elastic chest forces try to pull the parietal pleura out from the visceral, from the lungs. and they pull in opposite directions. So both forces, and predominantly elastic recoil, of course, they tend to decrease, to increase volume of the intrapleural space, but as volume increase is impossible, it results in decrease of pressure. Intrapleural pressure decrease. So you may understand the pressure in the intrapleural space is always negative in normal case when lungs are not collapsed. And as lungs normally are stretched in all directions from the roots, the pressure is always negative. Just it may become more negative when degree of stretching increases. What happens during inspiration. That's why pressure becomes more negative during inspiration and becomes less negative during expiration. Let's consider elastic recoil of the lungs. First, it's proportional to the degree of lung stretching and it is directed oppositely. From physics, we know such an equation that force, elastic force, is proportional to the degree of stretching. Here it's x, but direction is opposite to stretching, so it's minus, and k is just coefficient. And lung stretching, at inspiration it's minimal stretching, but it's present. And so there is certain degree of stretching, let it be x. Then elastic recoil becomes high when degree of stretching increases. So now let's make an inspiration and lungs become larger. So degree of stretching clearly becomes higher. So it's additional stretching. Therefore total stretching becomes higher. And similarly elastic force becomes higher. And when it stronger pulls visceral pleura out of parietal, we can expect greater negativity of the pressure. More minuses appear in the intrapleural space. So I hope it's clear. And now just imagine that it's closed space with negative pressure. Just imagine if there is any connection to the external atmospheric air, this negative pressure inside the intrapleural space is less than atmospheric. So immediately, if there is a connection, atmospheric air will start to move into intrapleural space because air simply goes into area with less pressure, from high to less, like a wind goes. So here it will be something like wind going into intrapleural space. And this state of air accumulation inside the intrapleural space is called pneumothorax, easily translated as air in the chest. This is condition that occurs when air enters the intrapleural space. So, mostly air enters the pleural cavity from the lung, from outside due to injuries, but also it can happen due to lung diseases or infection, and even from lungs, from inside. The pleural cavity may be entered from inside. Again, see here we have elastic recoil, and therefore, and also we have another reason for negativity, a smaller reason, less elastic recoil of the chest. And as a result, we have here decreased pressure, decreased as compared to atmospheric, and so we say this is a negative pressure inside the intrapleural space. And air, if air is able to enter, it enters, and difference of pressures disappears, and negativity also may be at least decrease or disappear at all. And so if it becomes equal to atmospheric pressure, there is no more force that keeps lungs stretched. Lungs are kept stretched because lungs cannot be, the visceral pleura cannot be separated from the parietal. It's not glued, it can slide easily, but they cannot be separated, become distant from each other. But if there is no more pressure that keeps connected two parts of the pleura, the lungs will be collapsed. So there is no force that keeps the two parts of the pleura together, and lung corresponding and chest wall are not kept together anymore. So lung will move to the direction of elastic recoil, it means to the roots. and chest wall will become larger, more rounded. That's what happens in case of pneumothorax. Lung collapses and chest wall springs out. So pneumothorax may be not full, not complete. It can be collapse of the lungs only partial, because a limited amount of air enters the intrapleural space. But also it can be complete when air is exactly equal to atmospheric. Let's consider a case when there is not very great opening. Look at this knife. It makes the opening in the chest cavity. And this opening appears for a short time, and then due to contraction of the muscles around, and this opening closes. So a certain amount of air enters, but not until the full balancing of pressures, and pressure becomes at least less negative, higher than normal, and as a result of decreased negativity, you see, the lungs become less in size, partial collapse of lungs. So correspondingly, this is a partial pneumothorax. But let's consider from the other side. Let's consider a case when the opening is very great and it doesn't become closed by contraction of the nearby tissues. So this is the right side, shows the partial collapse of the lungs, and now left side. Let's make two blows, and you see opening is a big one, and air easily goes until full equalization with atmospheric pressure. No negativity at all, and immediately lungs, like a balloon with expired air, becomes just a piece of soft tissue around the roots, and all the space of the left side, of this side of the chest cavity, becomes simply filled with air, and lungs are collapsed and do not function at all now. So part of lungs does not perform its function. This is complete pneumothorax. If you may understand that one side complete pneumothorax, it's not a reason for immediate death, of course, just a limitation of the physical capacity of the person, a limitation of oxygen delivery and oxygen usage. But bilateral, both sides collapse of lungs, full, means stop of delivery of oxygen at all. So it's a death. It's a complete collapse of the lungs. Let's consider how collapsed lung can look on X-ray. First, a schematic presentation. The black color shows the air. It will look black on the X-ray because X-ray come without any obstacle. There is no tissue. This is not complete, of course, it is small pneumothorax. Then, as you can see here, it's a large pneumothorax because only a little piece of soft tissue of lungs can be observed around the roots. And now let's see real X-ray. You easily can notice that right side of chest contains lung because the vascular pattern clearly visible. Vessels passing through can be seen. They're like vascular tree. But to the left side of the picture, for the person it will be right side, but for the picture left side, you can see here all this black area without any vascular pattern, no vascular tree, means simply this part of the chest cavity is filled with air. That's why it's extremely black without any picture of the vessels. So this is right side pneumothorax, full, complete collapse of the lung. As for the small pneumothorax, in healthy adults it may disappear without any treatment because pleura is able to absorb air gradually. With its negative pressure, air becomes gradually removed and finally disappears, and lungs correspondingly become fully stretched again. For larger pneumothorax, it's necessary to do certain treatment, and usually it's simply removing the air through a suction tube. Look at this scheme. Suction tube is inserted, and air is removed by negative pressure, and lungs correspondingly become stretched again. Smaller pneumothorax can be treated by drawing air with a needle by syringe. In many cases, they need to keep this suction tube for a certain number of days, and they add some antibiotics into the chest cavity so that there is no inflammatory process. This is treatment of pneumothorax. Let's consider in details the force that creates this negative pressure, elastic recoil of the lungs. This is number one force as compared to elastic recoil of the chest. And elastic recoil of the lungs, how it's created, why the lung tissue has not simply elasticity but ability to oppose stretching. And surprisingly, the first place is not taken by the elastic fibers in the lung tissue, such as collagen and elastin. First place is occupied by the very small force, as we consider in physics, very small force, surface tension of fluid that covers each alveolar surface. But number of alveoli is so great that it's little force for each alveolar spherical or practically spherical surface that creates the surface tension. This surface tension multiplied by number of all alveoli in the lungs makes great amount, bigger portion of the total elastic recoil of the lung, about 2/3, or if it's expressed in percentage, it's about 67%, 2/3. And the other 1/3 is performed by elasticity of these collagen and elastin fibers that are present in lung tissue. And if you summate it, 30 and 67, we have only 97. So 3% also remains. And these 3% account for the tone of bronchial smooth muscles. Certain degree of the contraction and the opposition to stretching creates additional 3%. Of course, it's negligible. But 3 factors for elastic recoil with its contribution in order of maximal, less, and minimal contribution, you should remember and should understand. As for elasticity of collagen and elastin, you can imagine this. Tone of smooth muscles also easy to understand. But let's consider in more detail surface tension, because physics was a year ago and perhaps the surface tension is not remembered well by now. The surface tension of fluid. This fluid, as you remember, lines each spherical inner alveolar surface. You remember that humidity in the lungs is 100%, maximal possible amount of water vapors, and also each surface of the spheres of alveoli is covered by a thin layer of fluid. And spherical fluid surfaces have surface tension. And this surface tension creates the pressure that tends to close each alveolus, to collapse it. And now we come to the consideration of the law of Laplace. Laplace law says, you can see equation to the right side. The T here stands for surface tension, P for pressure, little r for radius. According to this equation, the pressure is inversely proportional to radius. The pressure that tends to collapse, to close, to make minimal size of each alveoli is inversely proportional to radius. So when radius increases, what happens during inspiration? We inspire and each spherical alveolus starts to be larger with greater radius. But in this case, according to physics law of Laplace, you see the pressure that tends to collapse alveolus becomes less. So progressively it becomes easier and easier to enlarge alveolus. But while radius decreases, like it happens during the expiration process, decrease in radius progressively makes it harder and harder to keep alveolus open, because pressure that collapses alveoli becomes higher and higher. So, taking into account that alveoli are not equal to each other, some of them are larger, some are smaller, you may expect that, according to physics laws, during inspiration, largest alveoli should become larger and larger. And during expiration, smallest alveoli will simply collapse entirely, close. Small alveolar closure will produce great decrease of the total surface area available for exchange. And when there are many large alveoli, they totally, collectively create little surface area. But surface area is important for oxygen exchange. So, if we follow these laws of physics, which are hard not to follow, we'll have these problems. Many alveoli will be closed after each expiration. And it's not easy to reopen them. It's different from making larger. So, look at this. This is a spherical surface of alveolus with bronchial, and also you can see a layer of water, of fluid. So radius and radius here. And this radius 2, shown in green, is 2 times less. And so if we place this 2 times less radius instead of R2 we get situation that pressure in the smaller alveolus is calculated as 2 surface tension divided by radius and additionally divided by half, 1 second, divided by half. Approximately it's the same as multiplication by 2. You see, if you divide by 1 and divide then by 2, it's equal to multiplication by 2. So actually pressure in the smaller alveolus that tends to collapse it is 2 times higher than pressure in the first large alveolus. So that's what is described by the law of Laplace, and you see this law is not good for our alveoli. Pressure in large alveoli that tends to collapse it is less than pressure in smaller alveolus. So you see what may happen, what could happen if we don't have specific escape from this law. Let's observe how. Theoretically, during expiration, pressure could become less and less for larger alveoli, so they become overinflated. And for smaller alveoli, each expiration may close them, and it's not 100% probability that they will be reopened again in the next inspiration. And now you see, this is our escape, the surfactant. You know it from anatomy, from histology. Surfactant is a mix of surface active phospholipids. They are produced by alveolar epithelial cells type 2 or pneumocytes type 2. And main among this phospholipid is, in short, you may simply say lecithin. It's also known from bioorganic chemistry and from biochemistry generally. Full name is dipalmitoyl phosphatidylcholine, but lecithin is short and easy. Lecithin. Let's see first. This is the one example of alveolar epithelial cell type 2. See, the other are simply epithelial cells, pneumocytes type 1, and this is big cell with type 2 that secretes surfactant. The surfactant is a blue layer that covers the whole surface of fluid in the alveolus. And this is the general structure of molecule of lecithin. You see, this oval shows the so-called head portion of the molecule, and this head, you see, contains charges. Phosphate group, polar, negative charge, and also another area where nitrogen also charged positively. So everything charged is easily dissolved in water with its H plus and OH minus. So it's soluble head. This is something that you know very well because you studied many times, studied the structure of the membranes, phospholipid membranes. So this is phospholipid present in the membrane also. So it's polar hydrophilic portion of the molecule, or polar head. And look to the right side, you see fatty acid chains, non-polar, CH, 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 or CH2 perhaps, CH2 basically. So these are fatty acid chains. It's a non-polar hydrophobic portion of the molecule, or simply tail. So head and tail. This is the structure of phospholipids generally and lecithin in particular. And now let's see how lecithin changes everything into the opposite. Surfactant. First, the surface word is in English clear, and surfactant comes from this word. So it's superficial substance. It spreads on the alveolar fluid surface only. It doesn't go deeply into water layers, just on the fluid surface, because its non-polar tails, it tries to take out of water. The polar heads are submerged into water layer, but it should float on the surface only, because the heads only can be dissolved in water. But tails, hydrophobic tails, they afraid of water, so they move out of water into air. And when the whole layer of superficial layer of water becomes not water but mostly phospholipids, the total surface tension is not anymore the high level of surface tension of water, but it's much less because it's phospholipid surface tension. Look, without surfactant, let's enlarge little portion of the surface. And this surface of fluid that covers the alveolar walls contains water dipoles, H plus, OH minus. And between these molecules, hydrogen bonds appear. And these hydrogen bonds make high level of the surface tension of water. This force, this is called surface tension of water, is responsible for creation of the perfectly spherical drops of water when they go down in the air, when they go due to gravity. They become perfectly rounded because surface tension tries to make this surface area as little as possible. And as little as possible surface area becomes when shape is spherical. So it's rather strong force that makes also nice drops of water looking rounded. So it's a high surface tension. But look, with surfactant, the surface tension of fluid is now not water surface tension, because so many molecules of surfactant are placed on the surface. Surface tension becomes much, much lower, practically 10 times less than water solutions without surfactant. And this surfactant is produced constantly by alveolar cells type 2. But it's not the only one function of surfactant, and not one of the main, but not the only one. General decrease of surface tension. But also remember that the surface tension and changes the pressure. The collapsing pressure becomes higher and higher when size decreases, and vice versa. And stabilizing of alveoli is done also by surfactant. And this stabilizing goes exactly opposite to the laws of physics. Surfactant helps to keep smaller alveoli open during the process of expiration and prevents excessive overinflating of larger alveoli at inspiration. Look how it happens. This is expiration moment. Radius is low. According to law of Laplace, radius decrease should produce high collapsing pressure. But with surfactant, you see, less size, surface area of the inner of the whole fluid surface becomes less, and molecules become thicker, produce thicker layer with less water between, because the concentration of molecules in each place, in each unit of surface becomes higher. More phospholipids create less tension, less surface tension. Increased density of molecules decreases surface tension, therefore decreases the collapsing pressure. So it stops decrease in size of alveolus. Opposite case, if large alveolus becomes enlarged during inspiration. But in this case, the total surface area of the fluid increases, but molecules number remains the same. So molecules produce less density, less decrease in surface tension. You see now, concentration of molecules per each unit of square surface becomes less, and it decreases surface tension less. So simply surface tension increases, and it stops the further dilation and inflating of largest alveoli. So decreased density increases surface tension. Therefore, collapsing pressure also increases, and it stops further stretching of alveolus. So alveoli are stabilized. During inspiration, the alveoli, especially larger ones, do not become overinflated. During expiration, alveoli do not become closed, especially smallest ones, which tend to be closed first. So you see, due to presence of surfactant, we generally not only have less surface tension and less, therefore stretching is easier. Let's come back to the first component of the elastic recoil. This is the surface tension of fluid. So you see, if due to surfactant surface tension decreases almost 10 times, it means that main component of this elastic recoil is decreased. So elastic recoil itself becomes less due to surfactant. And if elastic recoil becomes less, it's easy to understand that stretching of lungs becomes easier. You should contract muscles less strongly, because of easy stretching of the lungs. But all this due to surfactant. You see, with surfactant, we not only have general decrease of surface tension, so that elastic recoil is decreased. Also, with decreased radius, collapsing pressure decreases. And with an increase in radius, collapsing pressure increases, so it stops further stretching. So, alveoli are stabilized, and they all remain open during both inspiration and expiration. And their size changes, but not dramatically, without any predomination of large alveoli over small, which decreases the size of the surface area. So let's sum it up. All functions of the surfactant. First, in general, is a decrease of surface tension. And there are some consequences. If tension is decreased, as surface tension is the main component, 2/3 of the elastic recoil, you may conclude that in parallel there is a decrease of the elastic recoil. When elastic recoil of the lungs decreases, it makes less negative intrapleural pressure. Of course, our normal intrapleural pressure is due to already present surfactant, so it's normal. But if surfactant is higher or less, it changes the intrapleural pressure to with more surfactant, less negative. But what is important for clinical purposes, less surfactant, more negative intrapleural pressure, higher elastic recoil of the lungs. Then, lung compliance becomes higher. Compliance is ability to be stretched without great effort. Ability to be stretched higher with less pressure applied. So compliance is important factor, and it's opposite to elastic recoil. The less is elastic recoil, which is resistance to stretching, the easier stretching becomes. Easy stretching is lung compliance. So it increases. And also, generally, stretching of the lung during inspiration becomes easier. All this follows simply from the first function, decrease in surface tension of fluid. But then, stabilizing of alveoli is a very important function. Due to this, smaller alveoli do not collapse during decrease of radius during expiration, and larger alveoli are not inflated excessively during increase of radius during inspiration. Then, improvement of gases diffusion in the lungs. Both gases are lipid-soluble and easily dissolved in lipids, including phospholipids. So it simply helps to move easily for both oxygen and especially for CO2 to diffuse in the lungs. So now you see functions of surfactant. And why we study so deeply this surfactant? Because there are cases when surfactant deficiency is present. Actually, surfactant deficiency develops in people who smoke severely, especially severely. It develops in even due to air pollution may develop. So even without any smoking, it can be present to a certain degree, little. But number one case in medical practice of surfactant deficiency is in neonatology. In pediatric practice, when infants are born prematurely. You studied histology, maybe you remember that alveolar cells type 2 become mature by the end of gestation period. And if the infant is born prematurely, these cells are not functional yet. And the earlier, more premature this birth occurs, the higher degree of surfactant deficiency develops. So this situation is referred to as neonatal respiratory distress syndrome. You may predict consequences actually, because if you know functions of surfactant, you easily can predict what happens when surfactant is insufficient or absent. Look, increased surface tension. Main function is to decrease the surface tension. So no surfactant, surface tension is increased. Itself, it doesn't sound dangerous, but let's see. Surface tension is a main part of the recoil, elastic recoil of the lungs. So elastic recoil of the lungs is higher. When elastic recoil of the lung is higher, the ability of lungs to be stretched is less compliance. And by the way, higher elastic recoil produces more negative pressure in the intrapleural space, because elastic recoil is the number one reason for negativity. So if elastic recoil is higher, pressure inside the lungs becomes more negative, because lungs will pull stronger visceral pleura from the parietal one. So elastic recoil produces more negative pressure in the intrapleural space. Lung compliance is decreased, therefore, and it becomes harder to stretch the lungs during inspiration. Now we come to simple consequence that easily explains the problems in these infants. They produce each inspiration with great efforts. It takes a lot of energy to produce normal inspiration. So it already creates problem for normal oxygen supply. But next consequence is the instability of alveoli. Now it comes exactly when little alveoli after each expiration partially close. Closure of alveoli is named by the term atelectasis. Atelectasis. It's collapse of some alveoli, and the higher is the degree of atelectasis, the less part of lungs remain functioning. And if we lose mostly smaller alveoli, you may understand that we lose more surface area than when it can happen if we lose larger alveoli, because larger take the bigger space but provide not such a big surface area for oxygen diffusion. So smaller alveoli are closed during expiration and do not open sometimes during the inspiration. And in reinflation of the lungs is not easy. To open closed alveoli is much more difficult as already open, just to make it larger. Then the larger alveoli become even excessively inflated and they take more space in the lungs. And then again, the total surface area available for exchange decreases, because large alveoli are not able to provide such a great surface area as smallest, because smallest fill more space. Then finally there is a decrease of arterial blood oxygen content. Less opportunities for oxygen exchange and less oxygen enters blood. And arterial blood does not contain enough oxygen, and when this blood is supplied to the systemic circulation, it produces hypoxia. And firstly, it's a problem for the heart, for the brain, and generally for all the tissue that suffer from hypoxia. So you see, predominantly it's due to atelectasis, this hypoxia. Fortunately, there is a way now to treat surfactant deficiency, because there is artificial surfactant that can be spread into the lungs as a spray, and it creates normalization of the surface tension, stabilization of alveoli, and so on. But gradually, the own production of surfactant, due to gradual more and more normal functioning of the pneumocyte type 2 or alveolocyte type 2, finally help to remove this type of deficiency. The whole process of inspiration, therefore, can be presented at the following chain of events. This chain of events is cause-effect. So first, what is the reason, then consequence. Reason, consequence. And goes in logical sequence and goes much faster than we describe it. Look, first, respiratory muscles contract. This contraction makes the chest cavity larger. Chest enlargement. Due to enlargement of the chest, lungs become also stretched and elongated and become larger. And between them, you remember why it happens. Not because of true connection between lungs and chest. There is no true connection, but they are connected actually due to presence between chest and lungs, the closed space that is filled with fluid. This is intrapleural space. So here it's necessary to understand clearly why chest enlargement is followed by lungs stretching, expansion. Because between them there is space that cannot become larger. And when chest goes outward, the lungs simply have to follow, because visceral pleura is attached to the lungs, and visceral pleura must follow the parietal pleura. After lungs are stretched, the alveolar space becomes larger, and it results in a decrease of pressure in the alveolar space. Decrease of this pressure, actually it's equals to P alveolar decrease. It creates difference between atmospheric air and alveolar air. Atmospheric is higher, so air from outside. Due to this pressure difference, air goes into the lungs. Air inflow to the lungs, this is inspiration. Correspondingly, for the expiration, you can predict. First, respiratory muscles, inspiratory muscles, relax. Alone this is enough to produce expiration, but in many cases, internal intercostal muscles participate. Also, in some cases, abdominal muscles participate. So the chest cavity size becomes less. But at least one process of relaxation of diaphragm, so that it goes upward, makes smaller size of the chest cavity, and chest cavity is followed by the lungs. Lungs become smaller in size, and pressure and air inside becomes compressed, so the pressure increases. This pressure is higher than atmospheric, so the air easily goes out. Part of air goes out of lungs into the out of lungs, simply out of lungs. And so this is air, and this is expiration process.